And thank you. What else do you want to know now?
Is she having like some sort of like fevers, chills, night sweats kind of thing that's going on? Like, is she systemically ill, or is it like an inability to eat, or?
Excellent. So
what kind of
she
more driving?
denies fevers, chills, nausea, vomiting, diarrhea, really any infectious symptoms.
Is she taking her HIV meds?
Great question. She has not, so I will give you a timeline of this. This is like July of 2020. And this woman had not been seen in person and stopped taking her HIV meds about a month ago.
Because she like ran out or is depressed or?
Great question. So she has it. She's not out of the medication. And she says she just like didn't feel like she needed to. And then you ask about depression. Why do you ask about that? I think that's a really interesting, good question.
I don't think you lose your appetite.
Yeah, absolutely. And so she pretty fervently denies any mood problem. She says, you know, sure, I'm sad because I've been sick with HIV for a long time, and I'm not feeling great, but I don't want to hurt myself. I don't want to end my life. I think her, at some point in this, she does get a PHQ-9, and it was like 1. We'll just put that in. What else?
Any recent travel?
No, great question. Yeah, because this was COVID, and she said she really hadn't gone out of her house for a long time. She's been doing telehealth visits regularly with her doctors, and she was treated for a sinus infection about 3 months ago, but that, like, going out to get medication and groceries is really all she's doing.
Does she have any like memory changes or changes in like her like behavior or anything like that?
Good question. Why do you ask?
She could have like HIV associated dementia or any other thing.
Yeah, absolutely. So
But
she,
with like could manifest with that too.
yeah, like psychotic depression. Excellent. So she denies any memory changes or cognition changes. She actually says that it's, you know, it's kind of unclear in talking to her through all of this, like why she came in today. She says, actually, I didn't come in. My friend came over to visit me, and he thought I looked terrible, like looked weak, and like I didn't feel good, and so he brought me in. Of course, the friend's no longer here, but that makes a little more sense that she's not feeling acutely ill.
Has she been eating at all, or like how?
Yeah. So she says that she has about 20 pounds. She thinks she's lost at least 20 pounds of weight. She isn't eating anything. She says she can hold water down. And this is the first time now, finally, at the end of talking to her, she said, yeah, I haven't been eating since I finished chemo. Yeah. Exactly, yes. So I'm telling you as it comes out of the patient, unfortunately, you know, because I think that's an important part of this. But
release satiety, abdominal fullness.
So she says that she just like doesn't want to eat.
She just doesn't have appetite.
No appetite. Yeah, she's able. She drinks water, and she'll take very small bites of food, but other than that, really doesn't have a desire to eat. And so then, and you look through her chart, and find that she finished chemo, for, anal cancer that's believed to be in remission. It was initially diagnosed in 2013. 2013. And she's had a resection, and this was a recent round of chemo that she finished in February with a follow-up PET scan that had no significant disease activity. And there's no plans for additional chemo at this time.
So what's like her past medical and surgical history?
Yeah, so she has this anal cancer, status post-resection and chemo, vulvar cancer as well, status post-resection, and then hypertension and GERD, hypertension, chronic back pain, and GERD. That is all that she has, and those 2 surgeries are her really only surgeries.
Has she been admitted for HIV complications before?
No, she has not, but she has never been great at taking her HIV medication regularly. She admits that she kind of goes through phases that she'll take it really well for 6 months or a year, and then doesn't take it as well.
So no labs recently since it's all been virtual?
Yeah, no labs. Her last labs were in February.
What medications is she on?
Yeah, so. Meds over here.
You have a resistance pattern?
Awesome. Why do you ask that?
Because she's been on and off of medication. Also, when was she diagnosed?
So the diagnosis was actually more unclear than I would like. She's had HIV for greater than 10 years. And she was not very forthcoming about how she was diagnosed or how she contracted originally. But she has had some resistance testing. As a result, she's on Prestiza, Descovy, and Norvir. And that has kept her disease seemingly well controlled per labs for at least 2 years. And then in addition, she has famotidine, Oxy-5, TID, PRN, lidocaine, patch, ointment, and cream, and then doxycycline.
And when did you last finish her chemo?
February. She's gotten and no allergies to medication. So I think this is a time where I want to take a minute and just hear kind of Peter, what are you thinking about this woman, or how are you going to approach her exams, and what's on your differential?
I'm deeply concerned about this person. I would probably, before seeing her, just try to get as many records as possible about her cancer, what chemo she was on.
Okay.
I think there's something that I don't yet understand about her.
Okay, so I love that. I want to, you're uncomfortable and you don't understand. Why is that? What don't you understand? Or
I think that the fact that it was not the end of our conversation, that I found that she was just on chemotherapy. I think a lot of baseline labs or CD4 count would also be really helpful for going into this year. That would help the physical exam you're going to do, how much neuro needs to be, how broad your difference needs to be as far as infectious organisms. Also, potential malignancies associated with HIV are also on the differential.
excellent.
Very broad.
And excellent, and Dr. Albert says the vulvar and anal cancer, be very concerned about a disseminated HPV. Excellent, so I love that. I call that out because I think it's really important to recognize when, even right off the bat, a patient isn't following a disease script or you don't have a clear story, and as Peter just said, start to have a really broad differential. So you mentioned some specific things that you wanted to know before you saw her, Peter, including her chemo history. So I will give you that. She had chemo most recently with carboplatin and paclitaxel. It was dose reduced for her last, I think she had 8 cycles. The last 2 were dose reduced due to symptoms, mainly fatigue and loss of appetite. But from her, you look back at her previous labs, really unremarkable in the past. Her baseline creatinine is about 0.5 to 0.6, kind of fluctuated over the course of her chemo. And her only usual abnormality is a mild normocytic anemia with a baseline hemoglobin like 11.5 to 12.5. So very mild anemia.
How long ago did you finish chemo?
This is in July, so 5 months ago.
She had no food since
That's what she's saying. You're able to look, I can't remember, there's an attending, I think, at Denver Health who always says, like, the first 3 causes of weight loss are no weight loss, but you're able to look back at her weight from February when she did finish chemo, and it is down 20 pounds.
What was her CD4? Did you say? Sorry.
Pardon?
Her CD4?
Her CD4, yeah, so her last CD4, so 8 months ago, this was in November, was 179.
Does food taste the same to her?
Yeah, so she says she hasn't noticed a difference in taste.
She has COVID.
Yeah, no COVID. I feel like we should just start like either during COVID time, say like COVID could be or could not be COVID. And I think it is reasonable to, at this point, certainly consider COVID. She's immunosuppressed, and even if she hasn't gone anywhere, may have it. CD4, how many months ago was that? 5, 7, 8 months ago was 179.
Has her viral load been suppressed?
It has been undetectable for years. At least 2 years. Still can't spell. Okay. Any other questions before we move on to vitals?
Is she having diarrhea?
No diarrhea.
You have like no infectious symptoms, right?
Yeah, she's really non-focal in this exam. Her biggest complaint is malaise, fatigue, and loss of appetite. And that's what she's most worried about. Because she says, when you ask her if food tastes the same, she goes, yeah, it tastes good, I just don't want to eat it.
Does she have early satiety, like any dysphagia,
Yeah,
abdominal fullness?
excellent question. Because I think getting at, is this, you're not eating and you, like an aversion to food versus are you not eating because you can't eat or having trouble eating? And she says, like, no, I have no problem swallowing, I haven't been choking, I just don't feel hungry, it's not that I feel full quickly.
And no vomiting.
No vomiting, no, yeah. These are really good questions, kind of getting at all of this. And I should say, as we move forward in this case, there are a lot of things that come up, but the purpose of this case is more diagnosis than management of the issues that are coming up. So for her initial vital signs,
And she has access to, right?
yeah, absolutely, yeah, really good question. I think that's something that we can easily overlook, but especially in someone who, if she's like middle-aged, older, lives alone, it's always important to ask that. But she says, yeah, I have access to food. I get groceries delivered, or friends bring food and groceries to me. So the initial vitals, she actually hasn't had her temperature taken, but her heart rate is 103. Blood pressure is 106/67, And, respirers are 26, statting 96% on room air.
Sorry, is this clinic or,
This is like, you're seeing her in the ED. Yes.
We have one ED that's in here.
Yeah. So that's part of this is like what you'll find out, but she's coming in with this like weight loss of appetite, she's tachycardic, they said like at the very least she needs to get fluids and maybe some additional evaluation. Her physical exam is really non-focal. The initial exam is documented as no acute distress, non-toxic appearing, slightly dry mucous membranes, like tacky but not barren. Pupils are equal round reactive. She had a rapid heart rate with regular rhythm, good pulses, no findings in her pulmonary exam. Bowel sounds ×4, flat abdomen, soft, non-tender, non-distended, no lymphadenopathy, and no focal neurodeficit. She was alert and oriented ×4.
did she get cactus?
She's not cachectic, but she has loose skin, and is thin appearing. I think at this point her BMI is like 22. I'm just saying. Okay, so the big key here is what do we do next, and what do we want to order for her? Because obviously there's different approaches. I think we've already established that we're concerned about her, partially just because we don't feel like we know what's going on. And I think then the decision becomes, do you start ordering everything right away? Do you want to order a little bit to start and see what that reveals?
I feel like basic lab plus, imaging.
Okay.
TSH too.
Yeah, what was that, Jenny?
I feel like she needs cultures. I
Like
mean,
an infectious workup?
Yeah, like yeah.
Excellent.
Infectious workup plus CSH plus basic lab.
Okay, I love this. And I think I really like the idea to do an infectious workup as well. Even though she's non-toxic appearing, I think we know that she doesn't have much of an immune system seemingly. And so we don't know what she would manifest for an infection.
Oh, and the CD4 count.
CD4, perfect.
And a viral PCR.
Viral PCR. Viral and viral load, you mean?
Yes,
Okay.
viral load.
Okay, sounds good. So,
But if you're worried about occult malignancy, getting some type of imaging, I think will be pretty helpful with that too. I think the next step would be, if you don't see anything on there, maybe an EGD to look for any sort of luminal irregularities.
sounds good. And I will give you what was gotten, if that, like, what we got of that, what was gotten initially. Okay, and then white blood cells are 3. Hemoglobin, 12.2. Platelets, 82. See here, and we've got, total protein. I'm just gonna go for the abnormal liver ones, because there's a lot of other labs that aren't as important right now. But if you want specific ones, I'm always happy to get them. 2.1, 2, 70, 133, 37, alcohol is 180. And then CD4 comes back. I'll give it to you but it doesn't come back till a couple days later. 21, viral load is still undetectable. And COVID is negative. For completeness sake. Except I can't spell COVID apparently. That's really sad. Okay. So that was not what we wanted to do. Sorry, I'm messing up the screen for folks here. Okay. So, and then we want some initial, imaging, right? So I will,
Question.
yeah.
For her social history, does she like alcohol, does she drink, like drugs? Yeah.
Excellent. So, she is a former smoker. She has an 18-pack-year history, quit about 2 years ago. Just she said it was getting really expensive and didn't want to spend her money that way. And then she denies any alcohol use. She does use marijuana. She says she smokes about 4 joints daily.
IV drug use, not?
She denies any IV drug use. So I will say that, initially at this time, for her admission, we have only a few images. So we got an ECG that just shows sinus tach. I'm not gonna belabor that point. They also got a chest X-ray. I'll give you guys a minute to look at it. And they got a CT head that had no acute intracranial findings, no masses, no midline shift, no evidence of hemorrhage. But they said they'd recommend an MRI to better evaluate if there was concern for new metastasis. And what's your one to two liner on the chest X-ray? I see Dr. Albert looking at it carefully.
Did you want me to interpret it, or you want somebody else to interpret it?
I love your additions.
Let one of the residents do it first.
Yes, exactly. You make eye contact with me, Anita.
It looks like she has some like reticular type of infiltrate, more on the right than the left. But don't see any infusions, like the, cosmocratic angles look clear. Yeah.
Yeah,
So, I mean, overall, nothing crazy.
yeah. Any additions, Dr. Albert?
Well,
I should say,
there's-
what are your additions?
Yeah, it's too busy. There's too many lines. I think there's an interstitial reticular nodular infiltrate that's diffuse. You can see it near the pleura, both upper lobes and lower lobes. And that's all I see, actually.
Yeah. And that, yeah, they actually didn't comment on that, but
But,
it was just,
so in this setting, it suggests disseminated infectious disease. It could be disseminated lymphangitic cancer, but I think it's more likely to be, given her CD4 count, some sort of disseminated MAC or HPV or histocoxy, something like that. That would be my differential.
excellent. I think, yeah, and I think that was the initial thought from the folks in the ED as well, and those who admitted her. So let me go back to the whiteboard here. We have these labs, we have this initial imaging. Also, she gets blood cultures drawn, and we'll go now to kind of, before we go to hospital day 1, as you're admitting her and writing her H&P, what would you put down for her, like, summary statement problem representation? And I think it's an important one for this patient. I'm gonna go to the next screen. We can go back to that, I think, if we want. What would you note? I think we didn't belabor the labs, but I would note that she was hyponatremic to 124. Her creatinine was 1.1 from a baseline of 0.5, 0.6. Her other electrolytes were normal. She had mild elevations, or she had a pretty significant elevation in her direct belly, 2.1. Mild elevation in her AST and ALK phos as well, that were not seen before, and a new thrombocytopenia to the 80s. She's never had low platelets before. So how how would you, again, have a problem representation for her? I'll start us off. She's a 53-year-old female, past middle history, AIDS, vulvar and anal cancer. Status post-resection and chemo. Feb 2020, or I'll just say 5 months ago. Okay. Presenting with malaise and loss of appetite, found to have, what would you put that we found her to have?
Pancytopenia, decreased viral load, or decreased or from baseline, from prior baseline, and AKI. It could be concerning for, ongoing infectious process.
Okay.
Versus, possibly HIV associated.
Awesome. And I like that summary statement. I think I'm not surprised that everyone was having a hard time coming up with one. And I think this is a point where I want to point out, like, she does not have an illness script right now. There is not a, like, slam dunk, oh, you haven't been eating, you have hyponatremia, it's from hypovolemic hyponatremia, and we now slam dunk, we're good. I think she has a lot of different things going on that do not have a clear explanation. And I would really advocate for, at this point, saying, identifying and recognizing when to move from type 1 to type 2 thinking. And I would say, if not before for her, we really need to take a step back and examine things really systematically and have an explanation, I would say, for really every abnormality that we're finding. So I'll take us to hospital day 1, because she was admitted like overnight, and not much happened the first night. I will say hospital day 1, theoretically, if I can type again, okay. She overnight did get fluids. Her sodium stayed exactly the same at 124. Otherwise, she finally got a temperature taken about like 12 hours after she presented. And I don't know, I think maybe it just wasn't recorded for a long time, but she was afebrile. She remained tachycardic, and her blood pressure stayed on the low side, like hundreds over 90s from a baseline, or hundreds over 60s from a baseline of 120s over 80s. Otherwise, you round on her in the morning and she looks okay, but none of the things that brought her in have gotten any better. She still doesn't have an appetite. Her sodium is still low. Actually, I will say the one thing, her creatinine went back to 0.8 with just that 1 liter of fluid. So we fixed one thing. But what do we want to do for her now? The blood cultures still have no growth.
What imaging did she get already?
So she got a CT head that was non-focal, a chest X-ray, and an ECG.
Things can import,
Excellent. So why are you thinking about that? I love it.
like all of her symptoms, hyponatremia, like not budging with fluids. She's still a little bit hyposensitive.
Yeah, I think that's an excellent idea. They got it, and it was 36.
Did they do, AFB blood cultures and then like all of the serologies for like lactobacillus?
Yes, they did. So I think that was drawn the next day, because again, she was still looking non-toxic, but now that she wasn't getting better. So she got the AFB, cocci, histo, serologies, blasto, all negative.
I think she would benefit also from figuring out what's going on with hyponatremia. So like urine lights would be great, and LDH would be great as well for thinking like PJP with hyponatremia, or SIDH.
Did she get any like abdominal imaging with the belly?
Yeah. And sorry, what were those last things you were saying?
Like an LDH as
LDH,
well.
that's right. And I can't remember it right now. I know it was within normal limits. Actually, no, it was 248 and the upper limit of normal is 245. So, that I'm still staying within normal limits. I don't know how to interpret those 3 extra LDHs. But she got abdominal imaging. What do you want to do for the abdominal imaging? Yeah, so she does get a CT eventually. This time they got an ultrasound of the right upper quadrant, and I think they were most concerned about a liver pathology. It had a sonographically normal appearance. There was 1 gallstone, but the bile ducts were pristine, like 0.4 millimeters, 4 millimeters, sorry. And no wall thickening, no pericholecystic fluid, and no sonographic Murphy sign. And she did not, unfortunately, get any CTs at this time. They got an MRI brain ordered, again, with concern for possible new head mass. That gets done overnight. Unfortunately, just kind of the way of the world. And I will say,
Sorry, so her CT hip was normal, right? That's just like with the gonium?
yeah.
That's why, okay.
Yeah, exactly. There was concern for potentially a new mass or new process that would be better visualized with an MRI. And so at this point, the team is leaving for the day, very unsatisfied with what's going on with this patient. And I think it was either cross-cover's first call or the team's last call of the day. She fevers to 39.7. New fever. All of the other recorded temperatures had been normal, and she had not appeared febrile. So I know this is a ton about management, but what do you want to do?
Wait, sorry, was she ever started on antibiotics on admission? So it was just like, we'll culture, see if she presents herself, and then.
Exactly. And she had been so non-focal that they waited. Oh, smear. Okay, iPhone. I love that you want to smear. Why do you want to smear?
For new pancytopenia.
New pancytopenia. Excellent. And I will say that the smear comes back tomorrow. So because I think it actually, the team didn't get a smear for a few days, but since you guys asked for it early, we'll give it to you guys early.
Reculture, probably.
Yeah, so she gets pan cultured and she started on vancomycin flagyl. I think there would be an argument to be made that like empiric antifungals would not have been unreasonable for her. They chose not to, but I think neither here nor there in this case.
Do they have other hemolysis labs?
Yeah, what would you like?
What are haptoglobin?
Her haptoglobin is, there isn't a tick. I don't know if, I cannot say why there isn't a retic count. I think at this point, because her hemoglobin was like 11 was like close enough to baseline, they didn't get one. Let me find her haptoglobin. I honestly don't know if she didn't have a haptoglobin at this point. But because her hemoglobin was just about, it was near her baseline. Yeah, because her hemoglobin was 12.2 with a baseline of 11.5 to 12.5. So she was within her baseline. So overnight, in addition to the fever, she began having hallucinations. Yeah. So what do we want to do now? LP, exactly.
Yeah.
So the LP.
I would not like that as a crossover.
Yeah, no, she was
I
not.
would be like, oh shit.
I don't think anyone was really psyched about her at that point. So her LP comes back with normal glucose, normal protein.
The crossover intern have to LPR?
No, she was actually with the hallucinations, and because her blood pressure went down a little bit to like 90s over 50s, she got moved to the NICU, and so they did it in the NICU overnight.
Wow, that's wonderful.
Yeah. It was a gift to the cross-cover intern. I know, the like person who's hemodynamically stable and needs an LP on the floor overnight is every cross-cover intern's least favorite thing. The first tube did have like 250 RBCs, but there were 0 in the last tube.
Okay.
And there were 0 white blood cells.
What a noob.
And her
Just kidding.
meningitis PCR came back completely negative. Okay, so again, this is the time, again, we're like clearly, firmly in type 2 thinking at this point. When she got to the MICU, they also got a DFA, looking for PCP. And it takes a couple days to come back, but that was negative. So I'm gonna fast forward, I'll say this, the first smear she got was unremarkable. There was like 1 aneocyte, like, you know, like what everyone has.
Did you flow on that?
They did not.
Okay.
Why do you ask?
Just like, you think about like a lymphoma, like a primary CNS lymphoma, I mean, you
Excellent.
might miss on just like regular CT imaging, so.
Yeah.
HHV8 associated malignancies.
Excellent. So, and Ariana mentioned HHV8, and the associated malignancies. How do you, so I think this is where we firmly are stepping outside of like any box and there's not a clear pathway to go down. So you do start thinking of anything you can think of that could be causing this patient to be ill. And I will fast forward her course a couple days and tell you that on hospital day 4, her creatinine is better, her sodium has normalized, her mental status has gotten worse, she's continuing to hallucinate. She remains on the broad spectrum antibiotics, but there is no culture data, no infectious workup has come back negative to date. Her platelets are now 60, and her hemoglobin is 8.
Oh, she's a.
So, and I'll say her respiratory status starts to decline, and she's intubated for respiratory failure as well. So now we have kind of a new multi-system organ failure of unclear etiology.
Did they get the MRI brain yet?
Yes, so the MRI brain was delayed a couple of days because she was unstable and would not comply. But I think actually the day she got intubated, she got the MRI brain because that was when she would sit still enough. There was still a lot of motion artifact, but there were no focal intracranial findings, just age-related changes.
Did they rock her when she was intubated?
Yeah, they did. And there was, nothing came back. There was nothing. They did not. Or I guess maybe they did at some point, but it was late enough and nothing came back except for the fentanyl she was getting for sedation.
We don't have any abdominal imaging besides.
Yeah, so she did get the CT abdomen pelvis. And CT chest, abdomen, pelvis at this point. That day 4, she's just not doing well, and no one really knows why. So let me go to that. Okay. Oh, is this? Yeah, this is what I want. Sorry. Okay. So here, this is just for meningitis PCR. That was negative. And
Denver Health.
Denver Health. Why do you ask?
Oh, because we don't have those multiplex.
Oh, gotcha. Okay. So I'm gonna play this. It goes through the whole thing with not lung windows first and then lung windows afterwards. And I can go back to any section after it plays once if there's anything you'd like to see in particular.
I can't really read the bells anyway.
Yeah, I'm always like, yeah, I would call it a really big spleen.
Yeah.
And a really
It went a little too fast, but just a little bit.
Yeah, exactly. So I'll play it again. But I think like her liver is like, that might be why she's not, although, and this was, so this was also done, we had an ultrasound of her liver for when she came in, and she did not have hepatomegaly on admission. And her LFTs on the day she was intubated, are, let me see. And her Billy, were significant really for a Billy up to, 5. So continuing to rise, but not a ton. Yeah, so she does have, that was the main finding here, was hepatosplenomegaly and, some enlarged lymph nodes. Is there anything else that you see on there, Dr. Albert? Or any windows you'd like to go back to?
No. No. I was going to
Yeah.
say from the beginning, when she has a cholangitic picture, along with what looked like interstitial changes on her chest X-ray and bone marrow abnormalities, that a disseminated infectious process should have been high on the list. And everything seems to have been excluded except some of the unusual viruses. The other thing to think about that won't explain the pulmonary or bone marrow problems is a vascular abnormality causing hepatosplenomegaly. But I think that's not very likely.
We got like EBV or CMV or something.
Excellent. So they did at this point get sent off for those rare, uncommon infections that even in immunosuppressed people, we don't think of as being all that significant. And her CMV was, her IgM was non-reactive, as was, she got parvo as well, that was negative. Her EBV IgM was 117, with the upper limit of normal being 39, and the IgG was 75, with the upper limit of normal being 21. And the quant PCR was greater than 1.3 million copies per milliliter.
She didn't have a sore throat?
No. I know, right? But, so does EBV explain this?
I don't know if it does. I mean, it can explain components of it, but not everything.
Can we get a ferritin to get HLH?
Yeah, so we can get a ferritin. It's greater than 7,000. Yeah, absolutely, yeah. So she does. And so you guys got to it faster than the team who was taking care of her. But this patient did have HLH. So we'll talk about that a little bit. But the point here is kind of when to take a step back and say, this isn't making sense. It isn't fitting a disease process. And I think you guys got away from the infectious workup and infectious cause sooner, partially because you were able to get results sooner than the real time. But being willing to kind of readdress your differential. So let's talk about HLH a little bit. I think it's important, not because it happens commonly, but because it's unique and it requires prompt treatment. And it also just has a lot of unique features that should trigger you to start thinking about it early. So hemophagocytic lymphohistiocytosis, easy for me and everyone else to say. It's in the family of cytokine storm. And this is actually from a New England Journal of Medicine review article from December of 2020. So you can actually, it's a great article. I'm not going to pull out all of it. I think it's worth reading. It was a review article published in the setting of the increased incidence of cytokine storm associated with COVID. So I think it's worth just refreshing. The big thing here is that it can have manifestations in nearly every organ. HLH in particular is an incredibly rare disorder, especially in adults. It is most commonly seen in children, especially less than 3 months of age. The estimated incidence of admissions to tertiary referral hospitals like Children's is 1 in 3,000, but overall incidence is about 1 in 100,000. There's not an estimate of incidence in adults because it is so rare. But in a review of a little over 2,100 case reports worldwide, 41% were adults, were greater than 14 years old, and there is some sort of likely genetic predisposition associated with Japanese heritage, because greater than 50% were of Japanese descent or in Japan. The clinical features most commonly are fever, splenomegaly, bicytopenia, so just 2 lines down at least. They can have pancytopenia as well. Hypertriglyceridemia or hyperfibrinogenemia, and she had a fasting triglyceride that was normal, and her fibrinogen was normal as well. Hemophagocytosis, she did get a subsequent smear that had destruction of all cell lines. A ferritin greater than 500, ideally above 3,000. Low or absent natural killer cell activity, as well as a soluble IL-2 receptor elevation. This should be greater than 2 standard deviations above the upper limit of normal for her age. Hers was sent off, and the upper limit of normal is 858. Hers was 43,440. So very elevated.
And that's sensitivity in the percent.
That's the percent of patients who have it that present with it. So the diagnostic criteria most widely accepted is HLH 2004. Here you can, the QR code will get you to the link through the Health Science Library, and then you can sign in to see the full paper if you want. But generally it's based on having at least 5 out of these 8 findings. She had 6, with a fever, fever greater than 38.5, splenomegaly, peripheral cytopenia, with at least 2 of the following. I think she had all 3. She didn't have the triglyceride or fibrinogenemia. She had hemophagocytosis. They didn't assess the natural killer cell activity. Her ferritin was very elevated, and she had that elevated IL-2 soluble receptor.
How long did that take to come back?
A while. It takes about a week. So there are actually modified criteria in recognition of the fact that a lot of these, well, specifically the things that are going to cinch it, like that IL-2 receptor, most often aren't going to be available when you need to start treating it, because the linchpin of surviving this is having early treatment. So there are modified criteria where you actually have, if people have 3 out of the 4 of fever, splenomegaly, just a cytopenia and hepatitis, so any 3 of those, plus any 1 of the 4 of hemophagocytosis, high ferritin, low fibrinogen, or low natural killer cell activity, you can presumptively treat for HLH. The idea being that it's most likely HLH or any other cytokine activation. And the biggest caution being if you're concerned about a concomitant infection, which unfortunately sometimes people do have. And so the treatment tends to be, it's based generally on the HLH 94 protocol, and that you can actually get to the full paper there. It didn't really change much in 2004. The linchpin is etoposide and dexamethasone. This patient did get 1 dose of etoposide, as well as about a week of dexamethasone, but unfortunately passed away before she was able to recover. It is a very morbid condition. In adults, the 5-year survival is about 54%, and the best way to achieve remission is to have a stem cell transplant, because it is really a primary bone marrow process. Essentially, it's characterized, just going back to the cytokine storm, HLH is a pathologic activation of the immune system. Specifically, it's thought that the natural killer cells stop inhibiting the macrophages, and the macrophages are inappropriately activated against self tissues. Most often, for some reason, the liver, and so almost all patients eventually have a degree of hepatitis. In children, there can be different diagnostic criteria, including genetic markers, but it tends more to be a sporadic cases in adults, and so the genetic markers typically aren't checked. let's see, I think that's, most of what I have. Oh, the other, important thing is, it can't, as this, diagram kind of illustrates, it can affect nearly every organ system. And while these are kind of the most common clinical features, other common features include bleeding, diarrhea, rashes, conjunctivitis, and then actually hyponatremia due to SIADH from renal dysfunction.
Isn't HLH like a secondary to something?
Yeah,
Like the EBV?
exactly.
Okay.
And so that was, in this case, the thought was the EBV changed immune regulation leading to it, because it's anything that disrupts immune regulation. Most often, in children, it is due to a genetic predisposition. In adults, it's usually due to infection, and EBV is the most common infection. CMV and parvovirus are the other common infections. Also,
Did you treat the EBV? Like, what do you do about that? Or do you just?
like you treat that as well.
Okay.
It's just like any kind of secondary disorder, you treat the underlying cause as well as the primary, as well as that secondary disorder, and supportive care of any organ system dysfunction. Other common causes of HLH in adults are immune checkpoint inhibitors, especially nivolumab and ipilimumab. And then people with chronic granulomatosis disease are more likely to get it, as well as malignancies, especially leukemias, which was kind of one of their initial thoughts for her, and rheumatologic disorders, especially in children. Systemic juvenile idiopathic arthritis has a really high correlation with HLH in children. And then HIV in and of itself can cause HLH, but that tends to be more around the time of either initial infection or initial symptoms with HIV, rather than this late in a disease course. So that's why they also think the EBV was the culprit. Great work, guys. I think my biggest takeaway here is not identifying and diagnosing the HLH, but recognizing when there's not a disease script and when you need to think outside the box. Any questions? Cool. Thank you, guys.